everybody. It's great to be here. I'm Dr. Brett Haake. I'm here with my wife, Dr. Felice Haake. We're live from Icaria Concierge and Functional Medicine. It is, Wednesday, March 25th, 7 o'clock. We're excited tonight because we're going to talk about something that I think every American should know about. It's something that is the number one killer of both men and women in the United States and also men and women throughout the world, and it's on the rise, and that is coronary heart disease.
Yes.
What's interesting is that in this space, we call it, functional medicine, which I think is I don't know if I'd say that's a misnomer, but the best way to think about what we do is just hyper prevention. Okay.
Right.
And in this space, there's a lot of awareness going on. There are a lot of doctors that are getting more and more involved. I think the population is becoming more aware. And a lot of times we get questions, or we find certain clinics and they may focus on gut health, or they may focus on hormone health, or they may focus only on metabolic health or brain health, or some clinics that we found just focus on advanced cardiolipidomics. And I think that what's important is that it's everything.
Yeah.
Right? It's everything. And sometimes you might sit with a patient and they're going through a whole list of different issues, and there's one underlying issue that is absolutely the driver of a lot of their dysfunctions, but you're still chipping away at a lot of other things to make a more perfect, or help them become a better human being in terms of their prevention and functionality. But the thing is that I think that it's important to just understand that all of these different systems in the body don't operate in silos, they operate together. And I think what we're going to talk about tonight, and that is the development of vascular plaque, is a very, very good illustration of how metabolic dysfunction, poor environmental factors, lifestyle factors, potentially some genetic lipidomic predispositions, and these kinds of things can all coalesce to eventually lead to plaque, and how this is all kind of interrelated. And so what I thought was interesting is we kind of looked in preparation for the podcast, we looked at some of the epidemiology and some of the negative prognostic indicators with regard to not just coronary heart disease, but vascular disease in general. So you had some of those things on your computer.
Pulled up on my computer.
Yeah.
Well, first of all, I just want to say congratulations to you, because you just got boarded in Advanced Clinical Lipidology.
Thank you.
Yep.
Thank you.
And
it's not very enjoyable. The test was
very
really
easy
difficult.
test, right?
Yeah, right.
Very easy
Exactly.
test. But Brett's not going to say this, but I will. He's probably, although we haven't really searched deep, but he's more than likely the only anesthesiologist in the country that's boarded in this. This is a classic board that you see cardiologists get.
Kind of an odd pairing, yeah. I mean, it's not very often that you're meeting an anesthesiologist who's also boarded in lipidology, and it's not because anesthesiologists can't do it. It's just sort of a more of a clinical medicine picture. But you're right. It's a lot of guys that tend to be incredibly smart internal medicine doctors and cardiologists. They probably didn't struggle as much as I did to pass the exam, but thankfully I passed. But the genesis of me wanting to eventually get the board was I listened to what I thought was one of the great podcasts I really have ever heard, and that was, if anybody's out there, if they listen to Peter Attia, and he had a guy by the name of Tom Dayspring on his podcast, and it actually wasn't 1 hour. I think it was 5 or 6 different episodes.
It was.
And I realized that I didn't have a clue about what these guys were talking about. And what was also sort of the genesis of me wanting to understand this is having been in the cardiac OR and seeing the way that someone, a 55-year-old who has advanced coronary artery disease, responds to my anesthetic, and the difference between that person and somebody who doesn't have coronary heart disease that's exactly the same age. And I saw very clearly how that person with heart disease can become dehydrated while they're out cutting the grass and plop over and die. Yeah. And so I realized that, I'm kind of a tip of the spear guy, and I'm essentially flying through the asteroid field and then dropping the patient off in the ICU. And so I thought, what can we actually do as physicians to teach people how to prevent things that eventually lead to vascular disease, and hopefully they never get to the OR table, never get to the cath lab, and then maybe even add 5 to 10 good years on to the end of their life.
Yeah.
Or at least, we don't dictate when the good Lord calls you home, but at least increase the statistical probability that you'll live another 5 or 10 years if you can avoid. And one thing that we're going to re-emphasize over and over tonight is, if we're talking about heart disease, the development of plaque in the coronary arteries, the conditions that are necessary are exactly the same as the development of plaque in the brain, and also the development of plaque in the peripheral vasculature. Mm-hmm. The conditions are all exactly the same. It's the exact same disease. It's just happening in various parts of the body. And so that's what led me. And at the end of that podcast, Tom Dayspring said, for anybody that's interested, the Hopkins book on dyslipidemia is what he regards as one of the authoritative texts on lipidology. So as you know, we ordered that book. Yeah. And
small little book. I mean, like 10 pages? When I first
started reading it, it was like Greek. I was like, geez, it's like reading an opinion from Anton Scalia. It took me like 20 minutes to read one page, but I finally fought through it and was able to at least achieve the ability to pass the exam. And really what it is it's wanting to just add something to the clinical acumen so that we can actually give patients the tools to prevent this nasty disease. And so hopefully at the end of everything that we talk tonight, the call to action will be, hey, what can patients do and what can physicians do together to help try to minimize these risk factors and hopefully keep less and less people on the or prevent people from ever getting to the OR table.
Yeah, absolutely. So, okay, so we're going to do some epidemiology, correct, here? We're just going to kind of just
I thought
some
that was
stats
really interesting.
on it.
Yes.
So cardiovascular disease is kind of all-encompassing. Like when people think of heart attacks, we're talking about atherosclerotic cardiovascular disease, right?
Correct.
So you have to kind of like let's
get
down to the nitty-gritty there.
You can have a heart attack is what we call a myocardial infarction. So that's a big word, and what that means is you already have plaque in your vessel, in your blood vessel, and that plaque breaks off and then moves downstream and actually blocks the flow of blood through the blood vessel. And then what happens is you don't get delivery of blood and therefore delivery of oxygen to a certain part of the heart muscle. So we call that an infarction, a myocardial infarction. And that is as a consequence of having plaque or coronary heart disease. So you can have coronary heart disease without having a heart attack or a myocardial infarction, but coronary heart disease is the genesis of it. And also, like we said before, coronary heart disease, the same exact process that develops plaque in the coronaries is the exact same process that occurs in the brain when you're at risk for stroke, and the exact same process that occurs in the peripheral vasculature when you're at risk for what we call peripheral arterial disease or atherosclerotic peripheral vascular disease. So,
Yep. Okay. So that kind of gives us a little summary of that. So just to give you some epidemiology here. So global burden. So the world burden of cardiovascular disease is the number one cause of death worldwide. Approximately 20 million deaths a year globally, and accounts for about 32% of all deaths. And majority of the deaths, interesting, will occur in low and middle income countries. And then United States snapshot. So 1 in 5 deaths are due to CVD, or we're going to use that short term to make it easier. And then about 1 in 3 adults have some form of it. Okay, may or may not know that.
So repeat that: 1 in 3 adults.
1 in 3 adults have
some form of coronary vascular disease.
Yep.
That's an incredible statistic.
And I will wager a bet. I'd love to know, of those 1 in 3 adults, how many of them actually know it? Okay, like truly know it.
It's such a good point, and I know we've gone over that data before. I can't recite it off the top of my head, but I know one thing is that the majority of plaques that break off, that move, what we say distally or downstream, are plaques that impede less than 50% of the vessel.
Yeah.
So those are plaques that typically are not, when you look at them under what we call a cardiac catheterization or a CT angiogram, they're not impeding the majority of that vessel, which is another. So it doesn't really take a lot of coronary heart disease to potentially lead to a plaque breaking off and then rupturing and then moving distally. So that's an interesting
and
stat.
here's this one got me. A cardiac event. Okay, so a cardiac event like a myocardial infarction, like a heart attack, occurs every 40 seconds. So
in the United States.
Yeah, this is the United States snapshot. And then lifetime risk, 50% for men, 33% for women. I always found it very interesting. And I'll try to cite the statistic intelligently here, but basically men always usually lead women in heart disease up until one point, and women will catch up. And when is that?
Menopause.
Well, interesting. You lost estrogen, you lost progesterone, and now all of a sudden you're neck and neck with men in your risk for having a heart attack.
And this is a great side note, we're going to talk about what all these things mean, as we go through lipidomics and all those kinds of things. But we as you and I have done, we're kind of rewriting our codex for our clinic, and we're looking at a lot of different things. So we've kind of gone back over the data with regard to hormones. And what's fascinating about estrogen is that estrogen actually lowers the LDL particle number, and we're going to talk about what that means. Estrogen lowers ApoB, and we'll talk about what that means. Estrogen lowers highly sensitive CRP, and estrogen upregulates something called nitric oxide synthase, and we're going to talk about what all those things mean. But all of those things that I mentioned are good for the heart. They're good for the blood vessels, and it's part of the reason for why, if you're a premenopausal female without familial hypercholesterolemia and you don't smoke, you are not going to get coronary heart disease. The overwhelming likelihood is you're not, unless you're maybe an IV drug user, or you've got some other really, really, something that's going to give you a lot of inflammation. But the overwhelming majority of premenopausal females who don't smoke do not get coronary heart disease, and the reason for that is they have estrogen. Period. End of the story.
Yep. And it is such a preventable disease. Like that's what blows our mind. I mean, we didn't really see this 100 years ago at all. Okay, because the reality is 100 years ago we were dying from communicable diseases.
It's such a good point. Prevention. It is a preventable disease, and I think what we have to get better at, we all know we have to get better at our lifestyle in the United States. We have to get better at our lifestyle in the United States, but we also, in the clinical setting, have to get better at being proactive about identifying risk factors. And I think that's one thing that we're going to talk about today.
Yes, I have that. Actually, that's the next thing I was going to say. So modifiable risk factors, the big drivers of CVD: hypertension, dyslipidemia, which, just colloquially is like high cholesterol, smoking, diabetes or insulin resistance, which is the driver, the mechanism that is underlying diabetes being the end stage, and then obesity, with the highest prevalence being the visceral adiposity, which is the organ fat, the fat around the organ. It's the fat you can't really see. When people see rolls on them, that's the subcutaneous fat. The visceral fat is really internally surrounding your organs, and that's the most dangerous. And someone can look thin and have a ton of visceral fat. And then a sedentary lifestyle. So those are your big, poor diet, of course, and then chronic inflammation and oxidative stress. So those are your modifiable risk factors, which are huge. What are your non-modifiable risk factors? Aging, Actually, I heard that once a long time ago, and I kind of like thought about it like, what? It's like the number one risk factor for having a heart attack is getting older. So blowing out the candles every year is your number one risk factor. But good, I want you to have a birthday every year. So that's not modifiable. The other non-modifiable risk factor, genetics. And then the other is sex. So males in particular have a higher risk. So those are your major risk factors. So with that being said...
And I think that it's important. You just talked about a lot of things that I think maybe not be all the way common knowledge, but you hear that a lot when you go to the conventional doctor is, hey, fix your diet or exercise, or hey, your cholesterol is high. But obviously based on the epidemiology that you just read, that's not enough because heart disease is on the rise in the United States. And it's the number one killer of both men and women in the United States and throughout the world. And it's rising almost, I don't know if it's rising exponentially, but it's significantly rising. It's a problem. So what do we mean when we say all these things? What do we mean when we say high cholesterol? And let's really break it down. What do we mean? So I think what we need to do is kind of take our listeners in scientific terms, but also layman's terms. What are the conditions that are necessary to develop vascular plaque? But before we do that, kind of lay out a little bit about the anatomy of the blood vessel and those kinds of things.
Before we jump into that, can I say one thing? Our listeners and most people are used to a standard lipid panel. And when we get deeper into all of this, we want to explain to the listener why the standard lipid panel is not adequate. I'm not going to say it's not necessary, but it's not adequate. It's not enough information to tell the physician or the provider what's going on inside the person sitting in front of them. It's not enough information. So here's my analogy, and then we'll go over what a standard panel looks like and what the panels we do look like. The standard panel gives you, six reference points. And the problem with that is it would be the same thing as me giving you 5 to 10 pieces to 1,000-piece puzzle. And I've handed you these 5 to 10 pieces, and I say, all right, now tell me what the picture is. What's the puzzle? You're going to look at me like, are you out of your mind? That's what we're doing with a standard panel.
There's 2 points that I'd like to add to that is one of the guys that teaches the A4M, which is the American Association of Anti-Aging Medicine, which you and I are boarded in, but one of the guys, the guy that teaches the cardiology component is a guy by the name of Dr. Mark Houston. He talks about, now he's out of Nashville, he talks about, I think there's actually 100 different risk factors. So it's not just obesity, hypertension, type 2 diabetes, dyslipidemia, those kinds of things. There's actually 100 different risk factors. And so what we do in conventional medicine is we say, okay, hey, your LDL, quote, cholesterol is high. That's your, quote, bad cholesterol. Your HDL cholesterol is, quote, your good cholesterol. That number looks okay. Mm-hmm. And then we wait for a blood glucose, and a hemoglobin A1C to rise to the point of being pre-diabetic before we actually start addressing your metabolic dysfunction. So what's interesting is you go to chapter 10 in the Hopkins book on dyslipidemia. It's one of the great chapters in the book. It's called Dyslipidemia and Type 2 Diabetes, but they actually get a lot into insulin resistance. One of the things that's quoted in that book is over 50% of patients that get diagnosed with type 2 diabetes already have plaque in their coronaries. So that begs the question, why are we waiting for a hemoglobin A1C and a glucose to rise before we're actually addressing the metabolic dysfunction or insulin resistance? And furthermore, what's a good way, what's a convenient way, what's an effective way and a quick way to actually measure insulin resistance? But before we talk about that, let's break this down into a couple of things. We're talking about the development of vascular plaque. You're talking about all these risk factors. Before we talk about that, let's just talk about the blood vessel, and then let's talk about the things that are necessary for plaque to develop within that blood vessel.
Okay.
So the inside of the blood vessel is called the lumen, and then what lines the lumen of the blood vessel are things called endothelial cells. What is on the other side of the endothelial cell is what's called the vascular intima, and then between the endothelial cell. Or the vascular intima lies between what's the endothelial cell and then smooth muscle cells. And so why I'm mentioning the vascular intima is that's where all the action occurs. That's where plaque develops. And what is necessary for plaque to develop is what's called an ApoB particle. And the way we measure that in the United States is by looking at an LDL cholesterol concentration. Like we're going to talk about, that's a very imperfect way of measuring that ApoB. But that ApoB has to move into the vascular intima. It gets oxidized, so it rusts, okay? And then that sets off a whole chain of reactions that lead to the movement of what are called macrophages. They start off as monocytes, and then they become macrophages, which are basically cells that your immune system has in your body that attack problems in the body, right?
Yeah,
so it's part of your immune system.
So they're kind of like the warriors in a battle, going out.
Right. So when the ApoB particle or the LDL cholesterol particle becomes oxidized, there's an alarm that goes out. There are receptors called VCAMs on the outside of those endothelial cells, and they send out basically like 911 signals. Monocytes attached to those receptors, those VCAM receptors, move into the vascular intima where they become macrophages. Those macrophages then engulf the oxidized LDL, and eventually those cells, they engulf enough oxidized LDLs where they become what are called foam cells. Foam cells over time coalesce to form plaque. So the summary of all that is what is necessary for the development of plaque over time is an ApoB particle, oxidative damage, vascular immune dysfunction, and inflammation. And to your point, the things that are necessary to form that plaque over time are, again, ApoB. So if you keep the blood pressure down, if you don't smoke, if you minimize insulin resistance, and you lower ApoB, you're going to significantly lower your chances of developing vascular plaque over time.
Yeah.
And what else is interesting is that, and this is where it all kind of comes together, is that those endothelial cells are highly, highly protective. Again, the endothelial cell is what lines the blood vessel. It stays between the lumen and the vascular intima. What they're mostly good at, one of their main jobs, is to produce something called nitric oxide. Nitric oxide is a molecule that protects the endothelial cell. It scavenges what are called free oxygen radicals, which are things that are really bad for that endothelial cell, and it also helps the endothelial cell dilate. When that endothelial cell can't make nitric oxide, those free oxygen radicals are not scavenged. They move into the endothelial cell, eventually into the vascular intima, and you have more oxidative particles or oxidative damage inside. Correct, rusting, and you get the development of plaque. And so we're also going to show how insulin resistance, so not only does it provide the inflammatory milieu for that plaque to develop, it also will increase the LDL particle number and the ApoB without a big increase in the LDL cholesterol concentration. This is really interesting, and this is important because LDL cholesterol concentration is what we measure, but it's not a criteria in the metabolic syndrome.
Right.
Of course, metabolic syndrome is how we diagnose insulin resistance in the United States. You and I both agree that that's, again, probably too late. We think everybody should be on a spectrum, which is, it's something that we've talked about in the past. But LDL cholesterol concentration may not rise significantly. What will rise a lot of times is the fasting insulin, the triglyceride to HDL ratio, your ApoB, and your LDL particle number. So we're going to talk a little bit about the difference between LDL cholesterol concentration, ApoB, LDL particle number, and then some of the different things that we measure to kind of offset risk.
And I just want to say it's really interesting. There's two things that I want to just touch on here before we move on to that next part, is that it's kind of the alarming history of medicine. I have this book called The Alarming History of Medicine, and it's hilarious. Like things we used to do that we all kind of giggle at now, like bloodletting,
Marty McCary wrote a great book called Blind Spots.
Yeah, it's kind of like that. It's just stuff we're going to kind of laugh at later on and go, wow, what were we doing? I think hemoglobin A1C is going to be in that. I think the way we diagnose diabetes and kind of wait for this end stage, level before we go, oh, we have to do something about this. So I think that's number one. And then there's this other interesting part. When you look at plaque, okay, years ago, I think it was late 60s, it was in the 70s, excuse me. The government kind of got involved with, trying to give nutritional advice. This is i.e. where the pyramid came from. Everybody remembers the pyramid. It is gone, by the way. It's a plate now. But anyways, it was the government got involved with nutritional advice, and they hired this doctor / researcher, Ansel Keys, and he basically was looking at, doing autopsies on bodies that had, died from a heart attack, and looking within these arteries. He collected the material that was in the arteries that had blocked the arteries, i.e. the plaque, and it was fat. And so he did the worst thing you can ever do in medicine. He inferred. So he made an inference, and he said, oh, there's fat in here, therefore it's fat that's causing this. And then,
as we both know, it's such an oversimplification.
Right. Then the pyramid was born. Right. Okay. And what was the pyramid? The top part of the food pyramid was a little bit of fat, and the bottom part of the food pyramid was breads and grains and pastas and rices and sugars. And the bottom line is we basically conducted an experiment on the American society, and the obesity epidemic, exponentially rose, and you just saw heart disease get worse and worse and worse. And I've heard this term, so I stole it from someone, but the Snackwell revolution. Remember those cookies that were low fat? I remember being in college, and we would order pizza and take the cheese off because we thought we were so healthy because low fat. It was the low fat revolution, and everyone got fatter. Okay. So anyways, my point being, you got a lot of things in history that we've made mistakes on. And I really think we're at an opportunity now with the advances in medicine and the laboratory we have at our fingertips to really make a difference and make a change here.
Yeah. And I think one thing that you and I have both found, we tend not to be super ideological as far as how we tell people to eat. And here's where I think there's a great book, actually. The guy's name is Rick Johnson, wrote Nature Wants Us to Be Fat.
My favorite book.
Another great podcast with Peter T. Rick Johnson. I think he's the chief of nephrology out at Colorado, and he primarily focuses on high fructose corn syrup, and rightfully so. So we know the problem with simple sugars. We know the problem with high fructose corn syrup. One of the issues, though, when you start getting into keto, which I think keto, I could argue keto all day long, but one of the issues is that if you're getting into these more pro-inflammatory fats, some of the saturated fats, and some of the fats that might lead to the development of what are called ceramides, which are even-chained, and this is kind of beyond the scope of this discussion, but they're even-chained saturated fats. So that means they have no double bonds, like C16, C18. Those fats can be just as insulin disruptive and cause metabolic dysfunction as high fructose corn syrup or your high glycemic index carbohydrates. So we always talk about a low insulin recruiting, low inflammation diet.
That's it.
That is probably 90% of the game, whether you want to do paleo or you want to do keto or you want to do Whole30 or you want to do carnivore, or, all these things, low inflammation, low insulin recruiting. And then we do like protein. We talk about that. We love resistance training. Muscle is the organ of longevity, and it's a tool in the armamentarium to maintain metabolic health as you age. But generally speaking, low inflammation, low insulin recruiting.
Yeah, not all fats are created equal, and not all carbs are created equal. So I think we just leave it there. So I'm sorry, I kind of pulled us away from what we were talking about. So
it's okay, yeah.
Next on the list, we did the anatomy of the artery, and then how the vascular plaque develops. And then you wanted to touch on, and I don't know if you want to do this first, the relationship of insulin resistance with erectile dysfunction.
We hit on it a little bit, yeah, and then negative prognostic lipidomics.
Yes.
So what's interesting, and maybe what we can do is send the audience some of the pictures that we use for our patients. But again, those endothelial cells, and this is why if a patient comes to you, a male patient comes, and let's say they're in their 40s or their 50s, and they've got some sexual dysfunction or erectile dysfunction, that is a canary in the coal mine that vascular disease is on its way or maybe even there. And number one, when somebody has erectile dysfunction, the insulin resistance has to be measured and has to be reversed. Why is that? Those endothelial cells that I mentioned before that line every vessel in your body, they have insulin receptors on the outside. Those insulin receptors directly signal production of nitric oxide. So they don't signal movement of the glucose into the cell, like for instance skeletal muscle cells. That insulin hitting that receptor signals the production of nitric oxide. When those endothelial cells become resistant to insulin, they don't make nitric oxide effectively. And again, you need nitric oxide to scavenge free radicals, and you need it to dilate the vessels. So you need it for good vascular health, but you also need it to maintain and keep an erection. So when those endothelial cells become resistant to nitric oxide, what happens is you get an elevated ratio of what's called endothelin-1 to nitric oxide. Endothelin-1 is a vasoconstrictor. Endothelin-1 to nitric oxide ratio vasoconstricts the vessel. That's why a blood pressure of greater than 130/85 is criteria for the metabolic syndrome. And that's the relationship between insulin resistance and high blood pressure. The other thing that happens, and this is part of the lipidomics profile that we're going to get into, is that and we talked about this a little bit, the fat cells that surround the abdominal organs, we call that visceral fat. When those cells become resistant to insulin, when they're lean and they're not inflamed, the appropriate response to insulin signaling is they take free fatty acids and incorporate them into stored forms of fat energy, and those things are called triglycerides in the cell. When they become resistant to insulin, they don't do that. Those free fatty acids that you get what are called lipid intermediates, which can be things like diglycerol or ceramides, like we mentioned before, or even triglycerides, they move back into circulation. And some of those lipid intermediates then move to the hepatocyte, the liver cell, where they disrupt insulin signaling at the liver cell. And what that does is there's four big things. It'll disrupt what's called gluconeogenesis or glycogenolysis, and that is insulin typically shuts down gluconeogenesis and glycogenolysis. So it disrupts insulin shutting that down. So what happens is your blood sugar rises. The other thing that insulin does at the liver cell is it shuts down the production of something called VLDL. When the hepatocyte becomes resistant to that, because it's resistant to insulin, VLDL rises. VLDL is an ApoB containing particle. And then the last thing that the liver cell becomes inefficient at is something that we call beta oxidation, and that is the conversion of free fatty acids into ATP. And so the cell starts to develop what we call a metabolic inflexibility. But that VLDL is an ApoB containing particle. And through a whole series of different reactions, what happens is that VLDL is converted into an IDL, okay? VLDL is converted into IDL. And so just to take a step back, there are four ApoB containing particles. LDL cholesterol, or LDL particle is one of them.
Right.
VLDL is the other one. IDL is the other one. And then something called LP(a). Those are the four ApoB containing particles. All four of those particles can move into the intima, become oxidized, and lead to plaque. When the hepatocyte becomes resistant to insulin, VLDL is produced, increases. VLDL through an enzyme called lipoprotein lipase is converted into IDL. Okay, and then what happens is an enzyme called cholesterol ester transfer protein moves triglycerides from the IDL and the VLDL onto the LDL and the HDL, and then it moves cholesterol ester onto the IDL and the VLDL. So the VLDL potentially becomes more atherogenic. The LDL and the HDL develop more triglycerides. That LDL and HDL then are mixed with an enzyme called hepatic lipase that then metabolizes or hydrolyzes those triglycerides on the LDL and the HDL. So what happens is the LDL becomes smaller, it becomes more dense, it increases in number, and it becomes more, so the particle number goes up. So now the LDL particle number goes up, and the ApoB has now gone up. The other thing that happens is HDL becomes smaller, and it's more likely to be excreted in the kidney. And so now you have that pattern of an elevated triglyceride to HDL ratio,
which is a big marker for insulin resistance.
Of metabolic dysfunction and insulin resistance. In the United States, they just increased the triglyceride cutoff from 150 to 175 for metabolic syndrome, and then the HDL cholesterol concentration in men is less than 40 and women is less than 50 as criteria for metabolic syndrome. Just to take a step back, though, ApoB is simply just a receptor site. It's a snake-like protein, apolipoprotein B, that exists on the outside of Lp(a), LDL cholesterol, the LDL particle, the VLDL particle, and the IDL particle. VLDL stands for very low density lipoprotein. IDL stands for intermediate density lipoprotein. LDL stands for low density lipoprotein, and then Lp(a) is basically an LDL cholesterol particle bound to what's called an ApoA. And all four of those particles have the ApoB on the ApoB 100, and they can all move into the vascular intima and become oxidized. So LDL,
and they are, just for visualization,
yep,
for the audience.
Yep.
VLDL, IDL, LDL, Lp(a) are sequentially getting smaller or more dense.
Let's throw
Lp(a) out, but those three.
Yeah, and so there's another, not to be even more confusing, but there's another particle produced in the enterocyte called the chylomicron.
Which is the biggest.
The biggest one, yeah. So the chylomicron is the least dense, and just to set the tone, LDL cholesterol particle is an amphipathic particle. That means it's hydrophilic. It likes water on the outside. That's how it travels in circulation.
Likes fat on the inside.
And it likes fat on the inside. So it's got triglyceride, cholesterol ester on the inside, and then it's got free cholesterol, phospholipids, and then the apolipoprotein B 100 on the outside. Its primary objective, the reason the LDL cholesterol particle exists, is to deliver phospholipids to the cell, to different cells to make cell walls, and then triglycerides to cells for energy. A lot of people think that it's the reason it exists is to deliver cholesterol to cells. It's not. That's a tertiary or role that's not one of the main roles. And the difference between VLDL, IDL, and LDL is simply just the amount of triglycerides that it has, its size, and its density. So chylomicrons are the biggest.
Have the most.
They have the most triglycerides, and they're the least dense, obviously, followed by VLDL, which still has a lot of triglyceride. It's big, and it's not very dense. Then IDL, and then LDL. Mm-hmm. And then Lp(a) is very similar to LDL. It's simply an LDL particle bound to what's called an ApoA, ApoA, and that ApoA is very similar to plasminogen, which plasminogen is typically a clotting, or what it does is it binds to a receptor, and it stimulates what's called tissue plasminogen activator, and it's actually for clot lysis. What the ApoA does is it binds to a plasminogen receptor, but it inhibits tissue plasminogen activator. So that Lp(a), the bottom line is that Lp(a) is really good at clotting. It's really good at moving into the vascular intima, and at a certain part of that ApoA, it actually attracts oxidized phospholipids at a very high rate. So it's an independent risk factor for things like coronary heart disease, aortic stenosis, stroke, and peripheral arterial disease. And it's something that should be measured because there's not really a lot that we can do from a diet and exercise standpoint to bring that.
It's very genetically modified, correct?
Correct.
Or implicated. Because I think I've read, and tell me if I'm incorrect here, you're the lipidologist, but 20 to 25% of the population produces a very high amount of that protein.
Yeah, I think it's actually related to the actual size of the ApoA. The smaller that ApoA is, the more the hepatocyte produces, so the higher the Lp(a) concentration. The bigger the ApoA, the smaller it produces, so the less. And that's simply, your concentration is simply a function of how much that hepatocyte is producing.
Yeah.
So there's really not anything from a diet and exercise standpoint that you can do to bring that down. There is a medication that you and I have been kind of watching called an antisense oligonucleotide, which is the way it's going to work is to target the messenger RNA in the liver and reduce that ApoA by about 80%, and therefore reduce the Lp(a) production by about 80%.
Where are they at with that, with the ASOs?
It's supposed to be really close.
Okay. So I'm a good example because my numbers are pretty good. I do all the right things. I eat well, I exercise, and I'm walking around with a pretty high Lp(a), which I was born with. I mean, I just genetically
and it's interesting too. There's a certain level, and I think you're right at that level where I think yours is like 189. The upper limit of normal is like 75. So I think you're right at that level where your risk, if you take someone with all of your risk factors, exactly the same as you have twice the chance of developing vascular disease as somebody else just like you with a normal Lp(a). But it brings up an interesting point. Because you're otherwise you have no inflammation, you're not a smoker, your blood pressure is controlled, you have no insulin resistance, and your ApoB is otherwise controlled, your risk, and you're on hormone replacement therapy, your risk of developing heart disease is almost zero. So if it's 0.001, 0.001 times 2 is 0.002. So you still have a very, very low risk. So just because you have an elevated Lp(a) doesn't mean that you're destined. You still have to modify these other risk factors. And another interesting thing is that my understanding with what's going on with the development of this antisense oligonucleotide is that they've demonstrated that it's safe. They've demonstrated that it's effective in lowering Lp(a), but they haven't demonstrated that there's outcome benefit. And the thinking, we don't know this, but the conjecture is possibly that in order to get these studies by a review board, all these patients have to have all these other risk factors modified. So they have to be on different medications to lower ApoB, blood pressure controlled. Otherwise, they could. So the thinking is that if all these patients already have a very well-controlled ApoB, is it really hard to find an outcome benefit because they already have, and it's a finite amount of ApoB. So if your ApoB is well controlled and Lp(a) contributes to that ApoB, your Lp(a) is high, but the rest of your ApoB is controlled, then your risk is significantly reduced. You still might be higher risk than somebody that doesn't have an elevated Lp(a), but you still have really, really low risk.
Yeah. And so all of these terms that we're using, VLDL and ApoB and Lp(a), really you're not going to get on a standard lipid panel. So which brings us back to why we feel, and by the way, we do standard lipid panels. Like in our intermediary, lab panels, we don't always do the advanced lipid panels. They're very exhaustive, and you're not going to get insurance to cover them over and over and over again, although they do cover them very well. So being said, all these different things we've just been talking about are on these advanced cardiac profiles or on these advanced lipid profiles that we do. We do one through Quest called Cardio IQ. We've been using Vibrance Cardio Zoomer. That's another really advanced test. So there's a lot. Berkeley Heart Labs. There's a bunch of different ones out there.
Yeah, a couple great points. The standard lipid, you hear this a lot too in the functional space. The standard lipid panel is worthless. It's not. The fasting glucose is not a worthless test. The A1C is not a worthless test. It's just, it is insufficient if you're worried about prevention and you're worried about really understanding disease. Let me give you another example. I just had a patient last week, probably weighs over 300 pounds. He's like, I'm not diabetic. I've been told I'm not diabetic. So, sure enough, we get his A1C, it's 5.2. His fasting sugar is 95. His triglyceride to HDL ratio was about 180 to 38. His LDL particle number was probably 2,400. His ApoB was about 125. The upper limit of normal is 90. So on our panel, it's less than 90 is normal. And his LDL cholesterol concentration was about 115.
Which is 15 points over.
Yeah, I mean,
100.
He's probably been told, hey, diet and exercise.
Yeah.
But his insulin resistance score was 99 out of 100, and he's 61 years old. So this is the classic guy who has all of these risk factors to develop plaque, and everybody's saying, oh, you're fine. You don't have diabetes, and so your LDL is just, hey, lose some weight. And so again, that insulin resistance is driving the LDL particle number up, it's driving the ApoB up, and it's also providing that inflammatory milieu in the vascular intima to develop that plaque. And I think this is a strong reason for why 50% of everybody that gets diagnosed, or over 50% of everybody that gets diagnosed with type 2 diabetes, already has plaque in their coronaries, and why we should actually look at insulin resistance in addition to your standard lipid panel, but also why we need to be looking at these advanced cardiolipidomic profiles. And just to take a step back, LDL particle number is total amount of LDL particles in the lumen of the blood vessels.
Like absolute.
So bullets, right? ApoB is essentially the concentration of those ApoB receptors that exist on the outside of those 4 particles that we talked about. Both of those are better prognostic indicators for need to treat and then response to treatment with regard to, quote, what we call bad cholesterol and then the LDL cholesterol concentration, which is the
What's
concentration. It's the concentration of LDL cholesterol on the actual particle, which is different than the actual particle number, which is looking at bullets.
Yes.
Meaning the total finite amount of bullets that can move through the lumen, through those endothelial cells, and get into the intima.
Can we liken it to LDL concentration, which is on a standard lipid panel, is like a relative, is looking at it relatively, and whereas looking at particle number is more absolute? Is that fair?
I think an easy way to view it is like, and just to use an extreme example to illustrate the concept, if I have one gigantic LDL cholesterol particle, that might give me a high LDL cholesterol concentration, where I could have 20 smaller particles that give me a lower concentration, but my particle number is higher and my risk is higher because I've got those 20 particles than the bigger LDL.
I got it.
That's
I like that.
Kind of an
I like
easy
that
way.
analogy.
Now, it's like that doesn't really happen physically, but that's an easier way to understand it,
So when we do these advanced lipid panels, just to give a little breakdown here, and then we'll get into our call to action, like what do you do? But basically, you have your standard panel, what most people know a cholesterol panel to look like. Then you go below that, and there's an actual particle, I forget what they call it on the panel, but it's like a subparticles, basically. The LDL ApoB, particle number, right? The size of the HDL, small, medium, etc. And then below that are your ApoBs and LP little a's, and what your number there is. Below that is a panel of inflammatory markers. There is one non-specific HSCRP, and then the rest are very vascular, inflammatory markers. And then below that is your insulin panel, which I love, that shows an insulin, an intact insulin, a C-peptide, and an insulin score. And I tell all my patients, the score is like a grade on a test. The test, but in this case, a 0 is 100% on the test, and 100 is an F. Okay, so it's a 0 to 100 scale. With anyone past that 100, they're pretty much diabetic. Typically, unless you have no beta cell dysfunction, then that makes it difficult to understand.
We find this all the time. It's actually good news and bad news.
Yeah.
It's classic. It's like, hey, you got a fasting insulin of 20 and your A1C is 5.3. So you have, the bad news is you have insulin resistance off the chart.
Right.
Good news is your pancreas still works and you don't have diabetes.
And we can fix this.
We can fix this. We can reverse this.
Right.
We even find patients that have diabetes, but their fasting insulin's like 16. And so you're like, okay, well, your pancreas is still working, but we need to think about reversing this metabolic dysfunction.
Right. So that's our full panel.
That's our full panel. Yeah. One real quick thing. I don't think we mentioned HDL. And HDL is basically, it's called high density lipoprotein. It actually has many of the same things that an LDL. It differs from those particles, those ApoB particles, in that instead of an ApoB, it has an ApoBig A. To make things even more confusing, ApoBig A, but it still has your free cholesterol and your phospholipids on the outside, and your cholesterol ester, and then triglycerides on the inside. But HDL's job is to move into the vascular intima and pull cholesterol out of the foam cells. So it pulls cholesterol out of the vascular
And HDL is kind of known as we hate this term, but we're going to do it. Yeah. The good one.
Good cholesterol. And what it does is it's called reverse cholesterol transport. It pulls cholesterol out of the vascular intima, and it either delivers it to the liver via a receptor called the SRB1, or it exchanges with LDL via an enzyme called cholesterol ester transfer protein, and it basically transfers cholesterol to the LDL in exchange for triglycerides onto the HDL.
Yeah, I always used to call it in medical school the sweeper. He's going through the artery, he's just sweeping it up and cleaning. Yep. So that's how I looked at it. But of course, we can get into the nuances there too. So what's our next part of our agenda here? Because we're taking a complex subject, trying to fit it in an hour, which we failed at.
Did we fail?
That's okay, but that's okay. So, no, I mean, it is an incredibly complex subject, and I think I have to pat you on the back here. I think you did a great job of taking that subject and kind of dialing it down. So, but what's the, ultimately the call to action here?
One thing I want to mention, and this is something that you and I are both starting to understand. One thing I think that we've neglected in the United States and surely throughout the world is the role that maybe some of these environmental toxins and metals actually play in terms of driving some of this oxidation of the ApoB. So we've just now started to get involved in, we do what's called a phenomenal test from Vibrant. Amazing. Called the total tox burden. So we look at your mold, we look at your heavy metals, and we look at your environmental chemicals, and we look at like 20 of the most common in each one of those categories, and then we can develop actually very specific protocols to get some of those metals out. Yep. All about prevention. One other thing is the omega-3 percentage by weight, the omega-3 index percentage by weight. It's an interesting little test that we do to look at your omega-3, and then you look at your omega-3 to omega-6 ratios. Vibrant, the cardiozumer, has an incredible profile on that, among other things, ceramide, toxicity, all kinds of things. But that omega-3 is hugely important. Just as an aside, the average omega-3 percentage by weight in the United States is about 3.5, which is in the red on our panel. The average in Japan is 8. Yeah. And in Japan, fish. they have 1/10 the heart disease that we have. One of the things that we love to study, Icaria is named after, are these blue zones, and we love to study the lifestyle and the habits of these people that live in these blue zones. And for the audience, blue zones are areas of the world where people abnormally live to be over 90 or over 100. Icaria specifically has a ton of men that live to be over 100, which is interesting. And all of these, you might find differences. For instance, obviously in the med, you're going to find more omega-9 with all the olive oil and all these kinds of things. But one of the things that we find everywhere in these blue zones are omega-3s. And so that's one thing that we look at. We have good sources. Of course, we always say, hey, find it in your diet, go offshore. If you can eat it offshore, great. But we have really good sources, nutritional supplements that we trust for the omega-3 percentage by index. But to get back to the crux of the issue, and what are we actually here for? What is our life's work, right? Yeah. Is we want as many people as possible in front of physicians like us in the United States, because we're really failing at health span and life expectancy and healthcare expenditure and all these things. The call to action is, if you're a patient, demand that your doctor understand this stuff and understand what your risk factors are. Just as an aside, patients are responsible for their health care, not the doctor. The doctor's job is to give the tool to the patient. Ultimately, the patient is responsible for their health care. The doctor's job is to take complex subjects, just like an attorney, and advise the patient on what they think the best course of action is, but also come up alongside the patient and say, hey, maybe somebody's never lifted weights. I'm not going to turn them into a power lifter. Right. Okay, hey, maybe go for a walk 3 times a week after dinner, and then go to the gym, get with a personal trainer, learn form and function for a day a week. Start with that. But the point is that patients need to demand this from doctors. But I think doctors, we need to start looking at these advanced cardiolipidomic profiles. I think we need to understand insulin resistance, okay, and understand how we need to teach, how we measure it, and what we need to do to teach patients how to reverse it. And then understand, the role that genetics plays in this, and then understand, basically the things that all of these different risk factors, and then how do we give the patients the tools so that they can actually prevent this disease from occurring. And the reality is we are there from a scientific standpoint. We can do damage. We can really, really fight the good fight. And I look, shout out to my good buddy, Mark Malias. We have really, really good cardiothoracic surgeons in this country. We have a lot of good ones right here in this area. They would all agree. We've had dinner with Mark. We'd all agree the best way to treat this is to just avoid the OR table altogether.
Right.
And that's what the goal is. And so the call to action is demand this from your physicians. And then once you have this information, understand as a patient that your job is to actually take this information and implement it. And there's no magic bullet. There's no magic pill, if you will. Not to say that pharmaceuticals aren't, we love certain pharmaceuticals, not to say that they're not of use and not of benefit, but ultimately this boils down to your choice to change your lifestyle, to understand what you're putting into your body from both a diet standpoint and also from a noise toxicity. One of the things that we made a change on is we stopped watching the news, right? Yeah. We go home and we're like, okay, shut it off. Let's go for a walk after dinner.
Right.
Sleep, stress, all these things. So diet, exercise, sleep, stress, various types of pharmaceuticals, but do what you can to understand this from both a patient standpoint and a physician standpoint. Cardio IQ, Boston Heart, Cardio IQ from Cleveland Heart Labs. Boston Heart has a phenomenal lipidomics profile. And then, of course, you and I, we love Cleveland Heart, but we also love Vibrant, their cardio zoomer. All these cardio lipidomic profiles are incredible, and they'll give you very, very detailed information about what's going on with the patient, and then you can develop an action plan to start reversing it.
Yeah, be an advocate for yourself. Arm yourself with the information. Bring it to your doctor. Listen, or your provider. At the end of the day, if you get pushback, you look for doctors who are doing this type of medicine, IFM, A4M. You can find doctors. So if your doctor's not, is reluctant or hesitant to kind of pull in this information and start, deploying this, then you look for someone who is willing or is doing it currently. So I think that's the main thing. I think ultimately we're at such a good point where we have the information, the clinical advances are there, and now it needs to be actually implemented.
Let's just take it a step further. I mean, right, you and I a lot of times talk about the problems, right? The problem is we spend more per capita on healthcare than any other industrialized nation, and we're last in life expectancy compared to any other. That's the bad news. The good news is where there are great problems, there is great opportunity, and there's never been a better opportunity than right now, particularly with the more, with all of the visibility that's starting to occur with this type of medicine and from both the physician standpoint and the patient standpoint. So this is the United States. We have a problem. We have to be honest about what our problem is, but we have to take this problem and fight it head on. And I think as we gain visibility and more people understand this on both the professional side and the layperson side, we can do damage, and that's the goal.
Well said. Very well said.
All right, well, that's it. We did not. We said 45 minutes.
Failed.
Like an hour,
That's okay.
All right. Well, thank you for listening, everybody. If you've got any questions, we'll probably put out some graphs and whatnot for the in some different tools for YouTube. But thank you for listening. Enjoy your weekend. Happy Easter for those that celebrate, and we'll catch you next time.